Hello everybody, I am recording for chapter 16, the anatomy of the heart. I'm really trying hard to figure out how to record with the slides going, and I don't seem to be making it work yet, so I promise you I'm hoping at least by the end of the semester that I can have that figured out. So go ahead and starting on the location of the heart, function, location, and size of the heart. I'm going to start on slide 2. If you could go ahead and join me by looking at your Google Slides on your Chromebook, that would be great. So, function, location, and size of the heart. The heart is a hollow muscular organ. It is about the size of a closed fist together, so about the size of this. It weighs less than 1 pound, and it pumps an average of 72 times per minute. With an adult, a normal range of a pulse or heart rate is going to be about 80 to 100, but that all depends on the age of the patient as well for the normal limit. The precordium is going to be the area over the heart and the great vessels, so it's kind of like the outer covering. You can see on that picture there the right lung, left lung, the apex of the heart, which is down into the left side of the heart that kind of swings over to the left side of the body. Moving on to slide 3 here, the heart's layers and coverings. So the endocardium, this is going to be the innermost layer, which is the smooth, shiny surface of the heart. The myocardium, a med term there, is going to be the middle layer or the muscular layer. This is the thickest layer of the heart and very, very thick along the lower 2 ventricles of the heart. Then next is going to be the epicardium, which is the outermost layer of the heart that also forms the pericardium. Peri meaning about and around, so this is going to be a really thin structure and sling-like structure with 3 layers within it as well. The 3 layers of the pericardium are going to be the epicardium, the visceral pericardium, the parietal pericardium, and then the pericardial space, which contains some serous fluid on it. So you kind of have like a small sac of fluid continuously around the heart. That's going to be great for like friction and so forth of the pumping action of the heart, being able to move around in your chest cavity appropriately. Slide 5 here is going to be a picture of those 3 layers of the heart that I just went over, and they are very, very important. Disorders that can happen with the pericardium, that outer covering or protective layer of the heart. A big one is going to be pericarditis. That's going to be an inflammation of that pericardial membrane, and it can cause a friction rub sound on auscultation of the heart sounds. Another thing that can be caused a lot is called a pericardial effusion. I will tell you, in my 10-15 years of ICU experience, I saw this one time. It was amazing that the doctor knew exactly what the problem was. She took a needle to the chest of the baby immediately and saved the baby's life within seconds. And she knew right what was wrong. So that's just going to be an extra fluid or buildup in the pericardial layer there, but can lead to death pretty quickly if not taken care of. Next, with disorders of the pericardium, is going to be called a cardiac tamponade. This has been on Grey's Anatomy before. If you want to look it up, you're more than welcome. But it's where the blood or the heart can't pump blood to the body. It is very life-threatening as well. This is where you're going to need that needle aspiration into the pericardial space and aspirate the fluid. So basically that pericardial effusion and the cardiac tamponade happening, kind of going hand in hand there. And that's what I was talking about, that neonatologist in my history, just going right in with a needle. She scared the crap out of me, honestly, by doing that, because I really didn't know what she was doing, grabbing a needle out of my bedside cart and going straight into the chest with it. So, but she did save the baby's life immediately, and it was quite a remarkable experience. The heart serves, going on to slide 7 here, excuse me. The heart serves as a double pump and 2 circulations. The double pump is going to be included the right heart and then the left heart. The right heart and the pulmonomic circulation, this is where the right ventricle pumps the blood into the pulmonary artery and then pumps the unoxygenated blood into the lungs where the respiratory gases, oxygen and CO2, are exchanged. Then moving on to the left side of the heart and the systemic circulation, so onto the rest of the whole body, the left ventricle pumps the blood into the aorta, which is that largest artery coming off the heart that pumps it out, the oxygenated blood, to the whole part of the body. There are two different types of circulation system. There's pulmonary circulation and systemic circulation. I've used those terms in the last couple minutes here. Pulmonary, obviously, is going to be that circulation to the lungs, where systemic is going to be the rest of the whole body. The next slide up here is going to be in a picture view of what I mean by pulmonary circulation and systemic circulation. And then moving on here to slide 9 is going to talk about the heart chambers and great vessels. The atria are going to sit on the top part of the heart. It's going to be the right side and left side. You need to remember anatomical position is very, very important for this. The lower two chambers of the heart are going to be the right ventricle and the left ventricle. The great vessels that come off of the heart are going to be the large blood vessels that carry the blood to and from the heart. They include the superior and inferior vena cava, the pulmonary artery, and four pulmonary veins, and lastly, that big, ginormous aorta that I'm best friends with. So the heart's chambers and great vessels, this picture right here, so slide 10, this should be your best friend until November 30th when your test over the heart is, because the second part of the test on Google Forms is you labeling this exact picture. So I am talking about all those black letters on there, the aorta, the pulmonary artery, the left pulmonary artery to the lung, the left pulmonary vein, the left atrium, myocardium, left ventricle. I could keep going, all those black things on there, the terms. Also, I put a copy of this image, a blank one, actually on Google Classroom, underneath the Google Slides. It's right underneath the Chapter 16 Anatomy of the Heart, but it's actually a blank one on this, so if you wanted to practice by printing it off and then sliding in those things from this slide right here, that would be great for you to practice. Moving on to the heart valves. The purpose of heart valves are going to be to keep the blood moving in a forward direction. You don't want it going backwards or sloshing back and forth. That's going to be inappropriate for the heart and not good gas exchange. There are 4 different valves in the heart. There's the semilunar valves and the atrioventricular valves. Listen, atrioventricular valve, that means it's going to be in between the atria and the ventricle, so it's helping the blood flow in from the atrium and into the ventricle. So they are going to be located in between those two things, and those are called the entrance valves as well. The atrioventricular AV valves contain cusp or flasps and chordae tendineae. Chordae tendineae are kind of these white hair-like projections after the flasp, and they're kind of creating that blood flow in the right direction into the heart's chambers. More specifically, with the AV valves, there's the tricuspid valve, tri meaning 3, so there's 3 different cusps on it. It is located between the right atrium and the right ventricle. The bicuspid valve, or 2 cusp, is located between the left atrium and left ventricle. Why does the AV valve close and open? It closes in response to increased pressure with the contracting ventricles. Moving on now to the semilunar valves, or slide 12, is going to be, these are called the exit valves of the heart. This is where the blood is exited from the ventricles. These include the pulmonic valve, the aortic valve, and the pulmonic valve is between the right ventricle and the pulmonary artery, and this sees the unoxygenated blood. The aortic valve between the left ventricle and the aorta sees oxygenated blood. These open and close in response to increased pressure as well with the contracting ventricles. So the same exact concept as the atrioventricular valves. They're going to close in response to decreasing pressure with the relaxing ventricles. There can be valvular incompetence, and this can be a problem with a heart patient. The valve may become leaky. It may need to be replaced. And there's a lot of different options for that. I am very familiar with this, as my dad has had many valve replacements in his life since he was a young child. The procedures are not as risky as they used to be, but it still means open heart surgery every single time. Valvular stenosis is going to be where there's a narrowing of the valve, and that makes it just where the blood flow is going to be constricted, therefore causing an increased workload on the heart. So moving on to slide 13, this is going to be a picture here of kind of showing you how to remember the atrioventricular valves and then that funny bicuspid valve, kind of remembering a picture with a description here. Moving on to slide 14 here, you should see a picture of the rib cage along with showing you where the pulmonic valve, the aortic valve, bicuspid valve, and tricuspid valve are located by picture. We're going to next talk about the heart sounds. So heart sounds of the heart are going to be a lub dub. The cause from the lub dub, or the sound, is caused from a vibration due to the closure of these valves. The lub at S1 is going to be the first heart sound. Due to closure of the AV valves and at the beginning of the ventricular contraction, this is best heard over the apex of the heart. The apex of the heart is going to be located on your left side, lower left side of the heart, okay? The dub, or the second heart sound, is going to be due to the closure of the semilunar valves at the beginning of the ventricular relaxation. This is best heard at the base of the heart. There are extra heart sounds, the S3 and S4 gallop rhythm, which are caused by vibrations by rapid blood flow. If you've ever heard of a patient having a murmur when you're born, guess what? If you had a murmur when you were born, that was actually pretty normal. And a lot of babies are born with a murmur, and then it typically goes away within the first 12 to 24 hours. If it does not, then they typically follow up with you, maybe get an echocardiogram, which is going to be an ultrasound of your heart. A murmur is going to be when valves become faulty and the heart sounds change. Moving on here, through the pathway of the blood through the heart, so we're moving past the objectives of 16.2 and the pathway of the blood flow through the heart. This again is the picture that you need to be able to label. So you are labeling the blood flow through the heart and basically labeling the heart at the same time. Moving on to slide 18 here. That slide is going to be basically how it is written out form. I do have a game for you guys, just as I did last year, helping you to remember how the blood flows through the heart. There are many different options on, if you Google games on remembering how to remember the heart, the blood flow through the heart, use those to your advantage as well. Also, there could be a shunt, which is a passageway that diverts blood from its normal circulatory pattern. There can be what's called a left to right shunt, which is going to be with a child with a hole in the intraventricular septum, or a VSD. An acyanotic child or person is going to be where it still pumps blood to the body, but not necessarily that well in the heart. The right to left shunt is going to be where the child or patient is cyanotic or blue, and it's because the blood flow is narrowed because of the pulmonic valve. Therefore, it is pumping unoxygenated blood, and the patient is blue because they're not oxygenated. Moving on to slide 20, the blood supply of the myocardium. You can see here pictures of kind of a bluish area and so forth. And you're looking at here, I want you to look at these coronary arteries at the beginning here. There's a right coronary artery and a left coronary artery. These coronary arteries supply blood to the myocardium. The right coronary nourishes the right side of the heart, which is not complicated, especially that right ventricle. The left coronary artery supplies the blood to the left side of the heart, which is especially the left ventricular wall. The coronary veins, which you can also see in this picture, they collect blood that nourishes the myocardium. The coronary sinus, this is going to be where it empties blood into the right atrium. Imagine that kind of like our sinuses, which are like hollow cavities that hold fluid most of the time. Moving on to characteristics of this coronary blood flow. The flow can increase as needed in exertion, so like exercise, or anything type of movement at all. Flow is going to be its greatest during myocardial relaxation, so when that heart muscle is relaxed phase, or the diastole phase. Coronary arteries can form anastomies, and these anastomies are going to develop with aging collateral. A myocardial infarction is a term for a heart attack. You know, the signs of this are really going to be, I mean, it's very, very common in women, let me just tell you, but men show different signs. They're more showing those telltale signs of left shoulder and arm pain, a crushing chest pain, where women typically actually can show very little to any signs at all. What we are going to treat a myocardial infarction with, to start off with, we're going to treat with MOAN. So morphine, which is a pain reliever, oxygen, aspirin, and nitroglycerin. So if the blood supply to the myocardium is decreased because of a myocardial infarction, then there's going to be a diminished coronary blood flow. This can result in ischemia of the tissue, which is where that tissue is deprived of oxygen and therefore dead, actually. It therefore then causes angina, which is also another term for chest pain. And then lastly, the full-on heart attack or myocardial infarction. Once you've had a myocardial infarction in that area of the heart, that tissue is forever damaged. The only way to necessarily fix that tissue area would be to get a heart transplant, which is quite a long list, but can be done. So do remember that emergency treatment for a MI or a heart attack is morphine, oxygen, aspirin, and nitroglycerin. That is one thing that you guys seem not to remember, that a heart attack is also called an MI or a myocardial infarction. That goes for animals, humans, or anyone. After a myocardial infarction, the dead myocardial cells leak enzymes and protein in the blood. So this is why we can draw blood very, very quickly when chest pain patients come into the lab, and the first thing we're going to be looking at is the troponin level. This is the #1 marker for a heart attack, and if it comes back elevated at all, we do know that the patient is suffering a heart attack. Also, another thing that may be elevated is a creatine phosphorinase and an aspartame aminotransferase. And then lastly, a lactate dehydrogenase. But the #1 marker is going to be that troponin level. Slide 25 here, talking about the cardiac conduction system. So we're moving on from myocardial infarction or heart attack. The SA node is going to be the origination of the cardiac impulse, or it's called the pacemaker of the heart. It determines what the heart rate is going to be, and I kind of think of it as like the electrical system brain for the heart. It determines, I told you, it determines the heart rate, is located in the upper posterior wall of the right atrium, if you're looking at that picture there on slide 25. Also, there are some atrial conducting fibers. They conduct that cardiac impulse through both the atria and the AV node. The AV node, moving on impulse, it slows as it moves through the node into the bundle of His, which is located near the floor of the right atrium or the bottom. The Purkinje system, or right and left bundle branches, conduct cardiac impulse throughout the ventricles. A normal heart rate, I'm sorry, I've been saying 80 to 100. That's way wrong. I knew that was wrong too. I was talking about blood glucose today with CNAs, and I was all caught up on 80 to 100, so I apologize. Normal heart rate is going to be 60 to 100. That makes a lot more sense now. So too fast of a heart is going to be called tachycardia, so anything greater than 100. And then bradycardia, so brady meaning slow, is going to be anything less than 60. So going back to that cardiac conduction system, your heart can basically stimulate itself without necessarily all communication from their brain. So that's why a patient can actually be brain dead, but their heart is still functioning. Slide 27 here kind of tells you how the electricity of the heart is going in the order. You do not have to remember this order for a test or anything like that. I just want to rest assure you of that. So how we're going to look at the electrical system of the heart is actually going to be by an EKG. So the next slide here is going to be a normal sinus rhythm that is shown on the EKG. So this is something that we can quickly put on the patient and be done very, very quickly, is then within the scope of practice of actually our CNA students as well. This picture is of normal sinus rhythm, and this is the cardiac impulse or the electrical signal that originates with the SA node, and the rhythm is normal. There are different parts of this EKG here that are labeled on the screen strip. The P wave is the atrial depolarization. The QRS complex, or kind of that original triangle that you see, or up-down, is going to be called the ventricular depolarization. The PR interval, so after that QRS complex, is going to be the time that it takes for the cardiac impulse to travel from the atrium to the ventricular. The T wave is the ventricular repolarization, so it's starting back up. And this ECG is recorded on blocked paper in order so that we can time it, and we block the counts by seconds. And so then that's something we'll learn closer to time, but just know that this is how we look at this. So also, if you are looking at the slideshow, as I asked you to do, there is a video that is the very last slide that I would really appreciate you to watch, because this is going to help you on your test with that labeling. So it should be called Blood Flow Through the Heart in 2 Minutes. So if you could watch that video on your own, that would be great. This lecture was not too long. I'm pretty proud of myself. 20 minutes and 35 seconds. Thank you. Happy Friday, and I am right next door if you need anything.